So it's my pleasure to introduce Dr. Maiti. He is the very pleasant neurosurgeon who has recently joined UAE Cleveland Clinic. And he has done his basic training from Calcutta and from NIMHANS, which is one of the pioneer institutes in India. And then he had his spinal muscular surgery training in Mayo Clinic, Arizona. So Dr. Maiti will be presenting neuromodulation in Parkinson's disease and other movement disorders. Welcome, Dr. Maiti.
Thank you, the organizing committee and the chairpersons, for inviting me. I am pretty sure that very few neurosurgeons are following this neurology conference, but at the same time it shows that how much my subspecialty is dependent on my neurology counterparts. So actually, to be honest, though I'm presenting the surgeon, but the team leader is always a neurologist for a case of DBS. And thank you again. So I will be brief because I am squeezed between two well-known speakers, and probably you are waiting to hear them more than me. So here are our objectives for today. So I will tell about the neuromodulation options. I'm not going into all of them. I will tell the most common ones, the deep brain stimulation and a bit of spinal cord stimulators, the evidence, the technologies which is evolving every day, of course complications, and where we are heading to. So the current status of movement disorders, if you see in last 20 years, 2 decades, the publications, you just put deep brain stimulation in PubMed, you'll see that publications are going up and up and up. So this is how the technology is evolving, and people are getting more interest into this procedure. They're trying new targets, new technologies, new IPGs, new lead, everything is new. So these are the only 3 conditions which is US FDA approved for movement disorder. Apart from this, epilepsy is also recently US FDA approved, but this is not our topic today. So for Parkinson's disease, this is one of the patient's experience. I will say it's though only the patient is like one person is affected, it actually affects the family for sure. So top part is the last 5 years before Sam had his brain surgery were very hard. I had to help Sam with everything, including getting dressed, getting out of bed, taking a bath. It was emotionally draining. The joy was taken out of our lives. I felt more like a nurse than a wife. We almost never socialized, as it was just too difficult. After surgery, yes, he is like a new man since having the surgery. He can do almost everything for himself now. He doesn't need his walker anymore, and I only need to help him get dressed in the morning before his medication starts working. We are not afraid to go out for dinner, shopping, and he doesn't shake as badly as he was doing before or doesn't get stuck or frozen. Surgery gave both of us back our independence and our marriage. Life is good again. We are truly blessed and grateful. There are several randomized controlled trial over last 10 or 20 years about Parkinson's disease. It's pretty available, NEJM, Lancet, Neurology, everywhere they're available. So first question is it a cure? No, unfortunately it's not a cure. It's for control but not for cure. So what all symptoms does it help? Does it help everything? Not really. The motor symptoms, tremor, rigidity, bradykinesia, and then the others are like when these symptoms get better, some other symptoms get better too, which you pretty well know. What doesn't improve? Speech, freezing of gait, especially when it is like on-state freezing. If it is a dopa responsive, there will be some improvement, but if it is on-state freezing, it's not going to help. Cognitive symptoms, dysphagia, dysautonomia. This is one of the slides. You just lost a similar slide in Dr. Fasano's dystonia presentation. This is his same presentation in Parkinson's disease. So here he showed that which all symptoms, motor and non-motor symptom improves with the different targets. So when should we go for the surgery? Should we wait or go early? So more and more evidence are coming out that to go surgery earlier, this is a result of early STIM trial, which came in New England Journal of Medicine, where they showed that before 10 years, like it was the median interval was like 7 years after presentation, they did the surgery and got good outcome. People got more enthusiastic. They tried even earlier. So this particular article came in 2020 Neurology with a 5-year outcome. Here they showed that all the surgeries were, it's a randomized control trial for 30 patients, and the surgeries were done before 4 years. In some cases, they did even like 2 years. I'm not sure, like probably we have to balance somewhere in between, we have to draw a line. So whether STN or GPI, several meta-analyses, several discussions, but it's kind of still unanswered, but mostly more and more data is coming that, okay, STN beat GPI, DBS really works, whether you do at STN or GPI. Mostly GPI, I will say that if there is a dyskinesia predominant or some psychological issues, concerns, go for GPI. If you are thinking about reducing the medications and longer effect, STN is better, and kind of battery saving effect is also good for STN. So this is the anatomy part. If you go anterior, posterior, medial, lateral, all of them going to give you trouble. You have to hit the bullseye. That's only part of my mind, like the neurosurgeons, and rest of everything is neurology. So I have to do my part just well. This is about GPI. Again, you cannot go anterior, posterior, medial, or lateral. You have to just hit the bullseye. So it is said that no two centers do DBS in a similar way. It's basically you follow your boss where you trained and just replicate that. That's the best way to get the success. That's what I believe. So these are the available systems, mostly available, like all 3 companies are available in the country now, if anyone are interested. And this is about their difference, how they are differed from one another. Of course, I'm not going to go into the details. So you can do either frame-based or frameless. I am more into frame-based at the moment, and we have all the image fusion technique, and then we register, we know, we have to see where is anterior commissure, posterior commissure. There are indirect targeting technique or direct targeting technique. Again, I'm not going into the technological details. You can use a O-arm, which can help your surgical time and give you an extra layer of surgical security that you have got hit the right spot, which is much better than an X-ray, which was the conventional way when I was a resident. But I feel that O-arm really gives you an advantage to be more precise. You can do MER. Some people are not doing MER, either they are not trained or they want to reduce the surgical time. But for me, the way I was trained, MER I will always go for an MER. This is kind of how you see conventional STN in one of our patients, kind of a brain blot at the root of the brain. That's how it feels before it reaches SNR. So again, if somebody is willing for frameless, of course, sometimes patients will come to you and ask for frameless. Yes, the cost goes a little bit high. These are the available companies, but not really, the results are not really better than frame-based, kind of more comparable. Yes, robots, we are using robot technologies, not in this country, of course, yet, but these are the other options. Again, as I said, that MER is really helpful in my practice. So whether to do both bilateral same day. So earlier, of course, we used to do bilateral same day, but this is where we kind of showed in one of our previous articles that doing one side at a time gives a better result, because by the time you are doing the second side, most of the patients are very, very uncooperative. They become stiff because they're kind of off medication from the day before, and they don't really cooperate. So, and also the brain shift is, okay, it's maybe very small, but here we are talking about a millimeter margin, sub-millimetric margin. So I don't want to take any chance. I do 2 sides in 2 different days if cost is not coming on my way. For tremor, yes, there are more options. For the difference between United States and here, we see lesser patients with essential tremor. There, the tremor patients were much more. Here, tremor patients are less. Yes, the other options are there. Somebody will ask you about focus ultrasound especially, but so far, DBS still holds its place, and it's kind of still preferable. These are, the VI means the target for the tremor. Again, several studies have shown over the years, and actually, to be honest, as a surgeon, DBS for tremor gives us more satisfaction because by the time patient is leaving the surgical room, they are almost cured. You can see it even before they go for programming there, you are going to get a good result. For dystonia, Dr. Fasano has already covered a lot of stuff, so it's good for me. And I will just say that according to this new classification which came like recently, the best candidates are DYT1, 6, or the patients with myoclonus dystonia or idiopathic dystonia. Inherited or acquired cases, they don't really do well. 2 points is most important. Yes, we have to be, as I said before, the neurology held the center position. You don't want to do a DBS for a functional dystonia, and you don't want to do it very late when the patient has already developed contracture and you are not going to get the good result from DBS. Again, what is the target, whether you could go for GPI or STN? Traditionally, we always used to go for GPI because we saw from DBS for Parkinson's patients, the dystonic patients who undergo DBS with PD, with dystonic component, their dystonia gets better when we choose GPI as target. That's how it started here. But as now we are seeing that the patients with axial symptoms, they get much better result with GPI, but overall dystonia, STN is not a bad choice either. There are a lot of innovations in last 10 years. There are imaging, so first part is imaging. We are using DTI, we are using fMRI, and we are using multiple other things to choose the target very, very precise. And now, instead of choosing a small target, we are more going for the connectome concept where we are targeting the circuit rather than a small target. So this is if you read recently, there are multiple articles about connectomics of VIM, connectomics of STN or GPI. At the same time, there is evolution of the technical part, the hardware part. So the IPG design have improved, the electrodes have improved, they're much more safer, they are MR compatible now. We have to think about concept of brain jacking talking in 2022. And the optimization of stimulation, we are using AI now to get the best result out of it and reduce the time for programming. So this is another evolution where we can direct the current to get the better result instead of the traditional results. The adaptive or closed loop, I will say this photo will be probably a better way to make you understand. So here we are using DBS only when it is needed and basically saving on other times. So here this gentleman wants to have coffee or tea during his reading something. So his brain is sensing, now he has to pour the coffee. So only that time he knows that it's going to shake his hand. So only that time his DBS is going to act and it will work so that his hand doesn't shake. Once the coffee pouring is done, then it stops of its own, and that way it can save the energy and it becomes more and more personalized. We are using other modalities like transcranial magnetic stimulation to improve the effect of DBS and optogenetics. Now we are talking about holographic to give an idea of AI and virtual reality to make our patients understand what exactly we are trying, or also for the teaching of the next generation. In background of COVID, of course, it became an issue because these patients were not coming out of their home. We got several patients who the surgery was done, their battery expired, all of a sudden they came to ED as a very steep state and nobody knew what is going wrong. In our experience, short experience, so this is one of the young patients. Here we do see a lot of young patients with Parkinson's. This gentleman is like early 30s. You can see how he is without medicine. Now with medicine, dyskinesia.
I know it is difficult. You're trying your best. Good.
Now again, during the surgery, first part patient is sleeping. Second part I wake them up to get an intra-op stimulation and check whether we can hit the target.
Act as if you're drinking water.
حاول كأنك بتشرب مي من كوباية.
Now bring it out for me.
رجعها رجعها.
Hold the cup.
امسك الكوباية
Pretend as you're drinking water.
وكأنك بتشرب منها. يلا. كأن فيها مية وقاعد بتشرب منها.
Very good. Can you bring it up?
رجعها تاني للدكتور.
One more time.
كمان مرة.
Right.
Very happy with his outcome. This is when he came back for programming. Again, this is like when it is turned off versus if you remember how he was walking with dyskinesia and now how he's walking after the surgery. And of course, it's not only surgery, as I mentioned multiple times, it's the programming and the neurologist who makes the difference and who makes sure that surgery is a success. This is another gentleman, an older man, where he was like severe tremor, as you can see.
Hold your hands up like this. Relax your
I'm not
hand.
sure
With
if
the
it has
left
got
hand, do
little
this.
bit rotated, but
Keep
you
your
can
feet in the
see
forward. Now count in Arabic from one.
both the
Relax your
hands are
hands.
still now. He's very happy.
Hold your hands
And
up like
also,
this.
he was almost not walking before without support because of its sake, and now he's pretty fast,
Okay, relax your
turning,
hands.
independent, and much more happier. Another patient who was not
Left,
really tremor,
right.
more of a stiffness and rigidity. You can see his walking speed and how he turns
Okay, sir, turn around.
left and right. There is difference even in an eye of neurosurgeon. Of course, neurologists can tell better.
Left, right.
So the key to success is, of course, the first is appropriate patient selections, placing the electrode in the right place, and post-op programming. The second part is only my part. First and third part is my friend's part. And I say that a good way to ensure good programming is keep your neurosurgeon away from it, because we don't really have patience to do that. The complications, yes, there are complications, but though there can be some hematomas, it's very, very unlikely the hematoma is so big that you really have to take it out, like this case. But most of the time it's very small. Thankfully, so far, touch wood, I don't have any, but I'm not sure when I will be the person who will have this photo in my own series. The infection, yes, infections are common. These patients are actually more prone for infection, especially the patients with Parkinson's disease, especially where the IPG is placed right in the chest rather than their cranial side. This can break also. These are old photos. As you can see, the new leads, extension wires are much better. They don't really break. It can cause a bowstring effect like the bottom photos, where patient will be annoyed and they will not leave you till you fix this. There can be some peri-lead edemas where you have to really treat with a long-term steroid as long as 60 days in these two patients where we had to do it. It's probably the main reason is either a venous infarct, that's very small. You don't really see in immediate post-op. You see in after 2 weeks, after 3 weeks, or after 1 week when the patient comes back to you at ED, that something is wrong. Or sometime a reaction or something, but it can give you a bad result. There are some earlier discussion that whether it changes your cognition and your personality, but most of the time when we did a post-op imaging, we found the lead were placed more anteriorly, especially for STN cases. That is the reason for the more of cognition effect rather than the DBS surgery itself. Yes, when the patient is not getting the desired benefit, before saying that DBS is wrong, you have to go through this process to see what exactly is wrong, whether it's the battery or something, the placement is correct, or just, unfortunately, the disease has progressed. There are ethical issues, as I said, like last 2 decades, there are several articles are coming and people are placing leads everywhere for every possible reason. I saw some big studies for diabetes, hypertension, and everything. So you have to be very careful what you're offering your patients and what all risk you are placing your patients into. As you can see, there are this many clinical trials posted and all are DBS. This is one very interesting curve which the think tank of movement disorder team, they publish every year. So it's like a first curve is like where people have peak of inflated expectation, and down the curve it comes into a plateau. So DBS for Parkinson's disease and essential tremor, these all indications has come to that plateau stage. Few words about spinal cord stimulations. Lately, spinal cord stimulation has garnered a lot of interest among the surgeons, and probably this is a bit of industry driven also. This works mainly, this was started for pain cases. Now we have used for other cases also. So you can see this chart. The 2009 was the first animal study, 2010 was first human trial. The initial trial, that didn't really work. But more and more people are claiming that, though they initially did only for postural instability and gait disturbance, somehow they found UPDRS score improvement also. But you have to look into their chart and see how many negatives are there. Unless there is a randomized trial, how much to believe and when to put your patient into that treatment. So which population are, so we still don't know how it works with levodopa, whether it will be reducing the levodopa, we don't know. What electrode? So cylindrical leads are which percutaneously can be placed. Paddle leads are kind of a surgically you have to place. As we don't know, we prefer paddle lead because it has a more wider coverage and it is giving a better result. What type of generator? The conventional ones, of course, was the first tried, and then burst stimulator and high frequency, which came in like last 5 years. We are using this also and getting good results. Which spinal level? The first trial was higher cervical level, like as high as C2. Lower thoracic is where we place for pain cases, but mostly it has been from animal trial, it has been said that upper thoracic area, thoracic 2 to 4, probably have the best results so far. Stimulation parameters, again, there are a lot of variations and a lot of discussions. Still, we have not got that sweet spot of frequency and pulse width. To summarize, it's a team approach, the team leader being the movement disorder specialist neurologist. Rest of the team member, you know, in this country I include 2 persons, 2 more team. One is the insurance team and the second is your hospital's financial team. They have to be in the same page to allow you to do the DBS surgery. DBS is standard of care now, it's not experimental, but spinal cord stimulator is still experimental. It's not a cure by any means, but it improved the control of symptoms and therefore improved quality of life. There are novel targets, multiple novel targets have been described, so it's not today's topic. There are technological innovations focused on improvement of safety, efficiency, and tolerability, and collaboration of other innovations. We always look into, say for example, this spinal cord stimulator is described for pain cases. We saw that we brought that into movement disorder. This is my team, and this is my hospital from where I earn my bread and some butter. Thank you so much. Thank you again.